Good morning, prominent speakers, distinguished guests, colleagues, students, and friends. I'm Zoe Chan, a Year 2 Global Health and Development Program student at the School of Public Health, the University of Hong Kong. On behalf of the school, I welcome you all to the HKU SPH Public Health Forum 2025 on Translating Science to Better Health. To start with, let me share the logistics of today's program. We will begin with a guest lecture titled Strengthening Multi-Source Infectious Disease Surveillance, Safeguarding Public Health, followed by another insightful lecture, Public Health is on My Plate, even when I'm operating. During the intermission, I encourage you to visit the student poster session, where we are proud to showcase 47 submissions from our RPG students this year. Following this, we will continue with the roundtable discussion on Research for Impact, Notes from the Field. Finally, we will conclude the event by presenting the Best Student Poster Award to recognize outstanding work. Here I share with you 2 QR codes. The one on your left will direct you to the forum webpage with information on today's program. The one on your right will direct you to the speaker's bio. Without further ado, let me now invite Professor Zhang Xiang, President and Vice-Chancellor of HKU, to give the welcoming remarks. Professor Zhang, please.
Good morning, distinguished speakers, colleagues, friends from government and partner organizations. It is my honor to welcome you all to this year's Public Health Forum with the theme of Translating Science to Better Health. Hong Kong enjoys the longest life expectancy in the world. This is no accident. It is human achievement of civil engineering, urban planning, and of course, the application of the science of public health. Our university has been an essential partner in this journey. We begin our legacy in 1887, that's a long while ago, when public health was the first introduced into our curriculum in Hong Kong U. For over a century, our university's faculty and graduates have been saving countless lives in Hong Kong by fighting the pandemics and reducing risks from unsafe air, water, and pathogen. Our School of Public Health was established 2004, about 20 years ago, a year after SARS pandemic. So this is a relatively young school, but what makes this school truly remarkable is not just its history, but also its impact. In just 2 decades, Hong Kong U has risen to become Asia's top-ranked institution in public health, climbing from 60th to 15th globally in the Shanghai ranking since 2021. Our relatively small public health faculty, representing 22% of the university highly cited researchers. That's more than 1/5. So school's excellence is also recognized through 3 WHO reference laboratories and pioneering research hubs. Our impact extends far beyond academia, from our critical contributions during SARS and COVID-19 to groundbreaking studies. Our researchers have translated discoveries into applied policies that saves lives. Our successful knowledge translation stems from our distinct approach to nurture talents. After all, we are an education institution. While we treasure our collaboration with international experts, we also nurture local scholars, professionals who combine global perspectives with local insights into how to apply the science of public health to Hong Kong. As we come together today for this important forum, we stand at an important juncture, building on our legacy while overcoming future challenges. I was told by one of the colleagues here that the pandemic is probably not too far, the next one within 10 years. So we got to get ready. And this is through the public prevention and also addressing healthy aging in Hong Kong. So it's not only pandemic, but also aging issues that we see not only in Hong Kong, but also mainland and most of the advanced countries. This requires interdisciplinary collaboration and knowledge translation that this forum seeks to promote. So, to all of you, thank you for joining us in this important mission. Together, we will continue translating knowledge into actions to create a healthy Hong Kong and world. Welcome you all, and I wish you all a productive, inspiring forum. Thank you.
Thank you, Professor Zhang, for the welcome remarks. Please be seated. May I now invite Professor Chak-sing Lau, Dean of Li-ka-shing Faculty of Medicine, to come forward to give the welcoming remarks. Professor Lau, please.
Thank you. President Zhang, our distinguished speakers from overseas, our colleagues, our friends, and our students, ladies and gentlemen. And first, I would like to thank David for organizing this and also for inviting me to come to say a few words with you. And it's just no secret, and I've said it many times, that actually if I had a chance to rebuild my medical career again, I will choose one of the two specialties, and one of which is actually public health. And there isn't enough time for me to explain to you why I actually pick public health, but suffice to perhaps share with you a little story about why I became an internist to start with from many, many years ago. And that was because when I was a medical student, I felt those physicians were really clever people, so I wanted to be one of them. So you could now understand why I actually want to try out public health, because of the achievements and also the work that our colleagues have done. We have just heard from the President how despite the small size of our School of Public Health, we have achieved what we have achieved. Now, in order to continue to excel, of course, we must regularly meet together. We must regularly, discuss the topics that we need to work on. So this annual event of Public Health Forum is a very excellent venue for us to do so. And if I go back to the history of the Public Health Forum, it was started 11 years ago in 2000, was it 11 years ago? 21 years ago, right? 21 years ago by Professor Anthony Hadley. And the theme of the first Public Health Forum, I think, was actually the role of the generalist in public health. That, I think, was what everyone thought public health was about, and that it was about, being a generalist. But in fact, fast moving forward to this year's theme, from science to public health, it tells us that, in fact, public health is more than just being a generalist. We actually apply what we find in our science, in the laboratory, to the clinic, and to the public. And in fact, it exemplifies exactly what our relatively small School of Public Health is doing. We have done so well. We have just heard from the President in the scientific discoveries. We have done so well in the public health policies, administrations, etc., etc. Then we'll come back to the Public Health Forum in order to make this work, and in order to make these sort of scholarly activities successful, we need the support of our students, of our colleagues, and very importantly, of our collaborators. Collaborators from locally and collaborators from abroad. So here I really need to thank, on behalf of the School of Public Health, our local colleagues who grace us on a Saturday morning and to speak to us. So I thank Professor Eng-kiong Yeoh, Director of the Center for Health Systems and Policy Research. And I thank Dr. Ling Fan, who is the founder of Health in Action and chairman of Forget the Not. And I also thank our colleague from Hong Kong U, Professor Zhang Xiang from the engineering faculty to come to share their wisdom with us. And of course, I must thank our overseas speakers. Shenzhen is not exactly overseas, but you do need to travel a bit to come. So Professor Hu Qinghua, thank you so much. And of course, Dean Teo and Professor Rebecca Grais of NUS as well as Pasteur respectively. So with this, I thank you again for attending this public health forum, and I wish the forum every success. Thank you very much.
Thank you, Professor Lau, for the welcome remarks. May I invite Professor Lau to remain on stage. Now, may I invite Professor Zhang, Professor David Bishai, all speakers, moderators, and panelists to the stage to take a group photo together. Thank you, everyone. Please be seated. May Professor Bishai please remain on stage to come forward to introduce our speakers today. Professor Bishai, please.
So again, thanks to our president and our dean for coming. I'm glad they've got us off to a great kickoff. My job is quick to introduce our next speaker, but I wanted to just note that we're having our event on the last day of Public Health Week. Around the world, groups like ours are meeting to celebrate our field. And I'm so glad our first speaker is a very esteemed practitioner of the science and the art of public health, of how to make communities healthy. Dr. Hu Qinghua is a specialist in infectious disease prevention, and she has used science of her specialty in molecular diagnostics, where we find out down to the cellular level and the antigenic level what it is that is causing these infections. She's currently the Deputy Director of the Shenzhen Center for Disease Control, and she's the Chair of the Microbiology Committee at the Shenzhen Preventive Medicine Association. She's had several prizes and honors. She's had over 100 peer-reviewed papers. One of her papers I'd like to ask her about is the science of yak infectious diseases. She comes from Sichuan, where there is a lot of interest in the microbiology of yaks. She won't be telling us about yaks today, but maybe we'll bring her back for her yak talk later. I'd like to just say you're in for a real treat with our special guest today. Thank you.
Thank you, Professor Bishai, for introducing the speakers. Please be seated. We will now proceed to the first guest lecture of today's forum. The topic of the lecture is Strengthen Multi-Source Infectious Disease Surveillance, Safeguard Public Health. May I now invite Professor Hu Qinghua, Deputy Director, Shenzhen Center for Disease Control and Prevention, to share with us. Professor Hu, please.
Good morning. Firstly, I would like to thank Professor Bishai David for inviting us to attend the Public Health Forum 2025. Yeah. So it's my great honor to be here to introduce our work. So today I'm going to give a talk in three parts. Firstly, I would like to introduce the integrated infectious disease surveillance. The second is about the prepared list of technology platform. Lastly, I will share our research data demonstrating how transfer into the public health policy. So Shenzhen is the largest port with 23 million people's populations and the highest density. It handles 241 million cross-border movements, and so there's a nerve and serves the international and domestic airlines 189 and serves 45 million travelers. So there is an import and export trade reach of the 3.87 trillion RMB. So this connectivity brings critical infectious disease import risks, such as the MERS cases in 2015 and the COVID-19 the first COVID-19 case, Wuhan, and recently the monkeypox and the dengue fever, and the ongoing challenges of the influenza virus. So Shenzhen faces the critical infectious disease challenges, so it demands that we should develop the rapid, effective framework for pandemic response, so that we should develop the framework. The component of the framework is about the passenger identification, outbreak identification, and the source tracking. So in Shenzhen, we is leading in developing a One Health-driven, integrated, multi-source infectious disease surveillance network, monitoring humans, environment, and alerts and animals. So for the population human surveillance component, we collaborate with the community health centers, district centers for disease control, state public health center, central hospitals, and other departments under the multi-sector prevention and control mechanisms. And this component of the population surveillance covers the notable infectious disease surveillance, healthcare big data surveillance, outbreak response monitoring, and the passenger identification network. So for passenger surveillance network, spanning the food, environment, and human populations over 2 decades. And this network has accumulated 30,000 isolates and 20 genomic sections. Now, yesterday we discussed with Professor Guan Yi, maybe these isolates is very few than Hong Kong isolates. However, for these isolates, there include the passengers influenza virus, SARS-CoV-2, and diarrhea passengers, and the enterovirus virus. So for the wastewater surveillance, that's because during COVID-19, with the assistance from Professor Zhang Tong's group, we developed this wastewater surveillance in community that is during dynamic zero COVID-19 period, and the 369 sampling points were covered. After the adjustment of the policy, so we adjusted to the waste treatment plants. Now there are 49 samples, 49 sites. For the animal surveillance, so we covered 7 related animals locations, such as the zoo and the animal sanctuary and the flower bird market. So that's the animal surveillance. So while we establishing the integrated infectious disease surveillance system, we are preparing for the developing 10 passenger identification platform that we want to detect the new passengers in unknown infectious disease, foodborne disease outbreak, and nosocomial infections. So this, I will tell 3 of these 10 passengers. The first is about the development of multi-passenger detection technologies, including improved molecular beacon probe, molecular melting curve analysis, and melting array. For the melting array, we have developed the molecular serotyping platform for screening 500 serotypes of enteropathogenic bacteria, such as E. coli. For this melting assay, there are 3 advantages it can cover. Firstly, it can cover over 60 target genes in a single reaction. The second, it can detect the mutations. Furthermore, it's very simple and accessible for this assay. The second, we have developed the sequencing platforms, such as the next generation platform, the 3rd generation, and the single cell generation. And we also developed the cultural max platform, including virus isolation and the unknown bacteria identification. For virus isolation, we have stored a series of cell lines, and we also developed organoid culture models. For unknown bacteria public health risk assessment platform, we hope to identify the passengers that is difficult to detect or uncultured based on the traditional methods. So this platform include sample collection, metagenomic, cultural max, and public health risk assessment. Maybe we can isolate many unknown bacteria, but whether it can cause the pandemic or epidemic, so we should do risk health assessment. So based on beyond 10 passengers, 10 technology platforms development, so we established the reference lab for rare and unusual passengers identification in Shenzhen. There is a tier the diagnostic networks. Firstly, the samples will go to Sentinel Hospital, then moves to the Shenzhen Regional Reference Labs for rare and unusual passengers. There are 4 regional reference labs, then goes to the reference lab for rare and unusual passenger identifications. So for this, because we have the keeping on developing capabilities, so we have responded to many succeed in responding to public health measures, such as in 1997 bird flu and the SARS epidemic and the COVID-19 epidemic. So next, I will share 3 landmark successes from our Shenzhen CDC. The first is about the response to public health emergencies. So firstly, I will share our experience on responding to COVID-19 pandemic. So this is a first case outbreak detection. So because with the help of our CDC's epidemiological data, we confirmed the first COVID-19 case detection, and our epidemiological data provided the evidence of human-to-human transmission for national COVID-19 policy. And of course, we will thank the Professor Eng-kiong Yeoh and the Hong Kong U Shenzhen hospitals. They worked a lot, they contributed a lot for this case detection. We also traced the epidemiology and transmission of COVID-19 in Shenzhen, and we had found that the tracing and the isolation and tracing the contacts can reduce the spread in the community. We also evaluated the practical performance of real-time PCR testing for SARS-CoV-2, and we also evaluated the transmission risk in recovered COVID-19 patients. And we think that for the recovered 19 patients, it's very low transmission. So we also evaluated in activity the SARS-CoV-2 vaccine booster against Omicron. So we translated our research data into the COVID-19 policy strategies. And for the wastewater surveillance, it also improved to the effective for the early warning and the detecting cryptic transmission during dynamic zero stage. And we also monitored after the policy adjustment. We also monitor the wastewater. We also monitoring the concentration and the variance across the 5 ways. For each wave, we have the main variant. So we also made the risk thresholds. We are divided the low, mid, and high risk, and we help the government to assess this COVID-19 epidemic risk. We also enlarge the surveillance to other passengers. Now there are 15 passengers. We also include antibiotics resistance gene screening. So for this, we use because we have developed a multi-source infection surveillance system. So we use the multi-source data to estimate 2 consecutive epidemic waves of Omicron. So now I will share the other 2 cases on the responding to football disease outbreak. For the 2021, we have E. coli outbreaks, and in 2024, there are another outbreak of E. coli outbreak. But we were using the routine API Q7 and fumarine rapid case, no negative. The clinical samples were detected negative. So we used our developed serotyping method, and we used the whole genome sequencing, and we used the cell lines. So we found that the novel E. coli serotypes causing football disease outbreaks. So these 2 cases then highlight that challenging of the identification of emerging passengers by using traditional methods. So we should develop some of the advanced technologies to respond to new emerging passengers. So secondly, I will share the transmission dynamics of enteric disease. We decoding the 2 salmonella to football disease passengers, because in Shenzhen, Vibrio parahomolyticus and salmonellas are the 2 most prominent of the football disease. So VP in China is a prevalence, especially in Shenzhen. So we develop the football disease surveillance, combined the food and the human. And for this research, we can confirm that the outbreaks are significantly underestimated. So we should develop a whole genome sequencing, and we can detect outbreaks earlier. Furthermore, we have found the hidden persistent reserves generate most of the outbreaks, so we had traced earlier. Furthermore, we had found the key ranging for the prevention and control, so that's the main target. We should find the key engine. Furthermore, we also have the decoding the salmonella, non-typhoid salmonella, by using epidemiologic whole genomic epidemiologist, and such as we decode the dynamics of salmonella typhimurium single variant, and for this strain, they are increased in past 5 years. So by using genomic epidemiologists, we found the plasmid driven the spread of this strain, and the cut of sleeps can find the network. We also decode the transmission dynamics of salmonella typhi and paratyphin. For our result, we found that this paratyphin spread from other 4 provinces. So we should prevent the imported cases. So lastly, I will share the successful successful case for the public health intervention and promotion. So this are the first in China. We established mosquito publish platform. So we promoting the dengue fever risk alert. Furthermore, in our disease environmental health system, so we deliver the high risk deaths for influenza, enterovirus, and other heat waves and other infectious disease. We also have successfully established this public health mobile PPT to promote public health neurology for the public. Now there are 14 million fines subscriptions, so welcome all of you to subscribe to our channel. Yeah, we establishing of the protective technology framework for merger and the emerging infectious disease to safeguard urban public safety, so including passenger accident detection, including the multi-source data-driven surveillance and early warning system development. We also study on passenger evolution, variation, and host-receptor interaction dynamics. Furthermore, we will use the data AI enabled to the decision making and precision control and prevention. So in Shenzhen, we are continuous to collaborating with the many national and international institutes and universities. And last year, on September 11th, we collaborated with Hong Kong University, with the Hong Kong Public of Health, with Professor Zhang Xiang and Professor Bishai David. So we have both of us develop the One Health George Bacteria laboratory. So we hope we have a more collaboration with the public of the Public School of Public Health. So yesterday we have more discussions with many professors in the School of Public Health, and we have many common interests. So we hope to have a more collaboration in details. So that's all. Thank you for your attention. Thank you very much.
Thank you, Professor Hu, for your lecture. Please be seated on stage for the Q&A session. We will now proceed to the Q&A session. Audience may scan the QR code on the screen to pose a question. Professor Zhang Xiang, Chair Professor of Environmental Engineering, Department of Civil Engineering, will be the moderator of the Q&A session. May I now invite Professor Zhang to the stage, please.
Actually, during our waiting for the coming questions, I think I want to ask what could be the next application of the sewage surveillance in Shenzhen and contribute to the One Health. Thank you. Yeah, I think you can try to discuss this question first and waiting for the coming question. Yeah, from the online. Yeah. Sorry. Yeah, my question is that now your presentation already show us that the sewage surveillance contributes significantly to the control of COVID in Shenzhen, and also you are trying to use that for some other pathogens. But in the next step, what could be the big picture for the further application of sewage surveillance to contribute to the One Health?
Yeah. During the COVID-19, we found that the wastewater surveillance is to some extent is very effective for early warning and the monitoring violence. But now, so because during that a special issue, maybe it's very useful. But now, some epidemiologists thought that because we have the human population surveillance, so what's useful for the wastewater surveillance? So that's my questions. I think because we also respond to the pandemic COVID-19. So how about next infectious disease X? I think for wastewater surveillance, maybe it can give us a picture of the baseline of the emerging infectious disease. So if we analyze some of the components of the bacteria from the wastewater samples, maybe we can detect earlier about the traits of some of the major passengers and the other new emerging passengers. So I think this wastewater surveillance give our overview picture of the baseline of this major infectious disease.
Okay,
So
I think if I summarize, it says well provide us the baseline and also may provide the early warning signals. Yeah. Okay. Now I see there are 8 questions coming online. Let me pick from the first one. Can you show us some more detail about the predictors of the pandemic development?
Yeah, details. So we is leading developing the integrated source effective surveillance network, because in Shenzhen we have covered hospitals and the hospitals, the communities, and the animals and the wastewaters. So we can use all the multi-source data to predict the emerging infectious disease. So because Shenzhen we have integrated from One Health, so I think that's we can predict.
Okay.
Yeah, for the dengue fever, we found the first case last year. We found the dengue fever in the community health center. Then for the variant XBB, we found from the wastewater surveillance earlier than the population surveillance system. So we should combine the multi-source integrated systems. That's I think that maybe is more powerful than other cities. Yeah.
I believe so. Yeah, Shenzhen definitely more skillful and more prepared for this. Yeah. The second question is about something about Hong Kong. I think you may not have the better position to answer that. The third question is about Shenzhen. So the question is, do you think Shenzhen is better prepared now for to handle the next respiratory virus pandemic? With the experience of the COVID pandemic, or will it be more difficult in some way? So that's a question, please. I think difficult question.
Yeah, that's very difficult questions. Because we have all of in Shenzhen, up to now, because I have been in Shenzhen CDC for 30 years. So we have, we truly that we succeed in many public health emergencies. I'm sure maybe we can, but we should keeping on preparedness of many technologies and preparing for developing more comprehensive integrated surveillance systems. Yeah, so we will keeping on. Yeah, we're keeping on. How to say?
Okay,
Keeping on.
Yeah, thank you for your answer on this. Personally, I believe, based on my interaction with Shenzhen CDC colleagues and team, I believe Shenzhen is better prepared for the next respiratory virus pandemic. And especially when people, get more familiar with the integrated surveillance system, including the Swee surveillance. I think we get more prepared for that.
I want to say, because in Shenzhen, the government, they are very focused on public health. So I think the government focus and the staffs in CDC focus, I think maybe we can be better prepared for the disease, emerging infectious disease, for the next pandemic. Yeah.
Okay. The next one is very interesting. What are the major findings from the animal surveillance activity? Yeah, what is the major finding and the major result from the animal surveillance activities?
Now we
No?
yeah. We collaborate with the animal centers.
Oh.
Yeah. But now because in Shenzhen, it's a market city, it's a modern city, so there's a the farms, there are not real farms, just only some ruins important from the other provinces. So up to now, we don't find the major animal disease. Yeah.
Okay, yeah. Another question is about what can Hong Kong and Shenzhen do together to prevent the spread of dengue virus to Hong Kong? So that's a question related to the dengue virus. Yeah.
Yeah, yesterday we have more discussion on how to collaboration between Shenzhen and Hong Kong. Yeah, I think that's a big questions. Maybe we should have the more policy to prove the collaboration between Shenzhen and Hong Kong.
Yeah.
So I'm sure because the government, Shenzhen government, they want to push the more collaboration between Shenzhen and Hong Kong. So I think maybe that's a very good in the future.
Yeah.
I think the next time we have more details on this item.
Yeah.
Yeah.
I think definitely, personally, I think Hong Kong and Shenzhen can do many things together to prevent not only dengue virus to Hong Kong and to Shenzhen, but also some other virus, other disease, based on the better communication channel and also the exchange of the knowledge, the technology, and I think that will definitely help. I think that's one of the purpose of this public health forum today. And we also see colleagues from Hong Kong CHB attend this forum. Okay, yeah, next, 5 minutes left, right? Okay. And do you think climate change is an important factor in the disease transmission? This is a very general question.
Yes, of sure. Yeah. Yeah, the climate change will change some of the infectious disease. So we should combine, that's why we want to combine the multi-source data, including the climate change. In Shenzhen, that's why there are many foodborne disease outbreaks, such as Weibio pneumonitis, Salmonella. I think that's one of the reasons is the climate change, and the climate is high. Yeah, so I think we should control the infectious disease under the One Health framework. Yeah.
Okay, thank you for the question. I think personally, I also think that definitely climate change is an important factor which may affect the disease transmission. Let's take dengue virus as an example. Now, I was told that even in my hometown, very northern part of China, there's some reported cases of dengue virus. Yeah. So which never heard before. Another one is monitoring mosquito population seems fascinating but challenging. Seems very interesting but very challenging. Would you explain how to do it? Mosquito monitoring. Yeah.
Yeah, for mosquito monitoring, we just say mosquito. Yeah, mosquito for dengue fever is our risks. Yeah, mosquito. We want to see. We have developed a map in Shenzhen about more than in 10 districts. there are about more than hundreds sites, so we want to check. But I'm not very familiar with these questions. Maybe I ask my colleague to answer this question. 关于
Okay.
文字地图 Yeah.
Yeah.
Welcome, Zhang Xiang.
Like BI or others, we 发布对外发布怎么说？we made the mosquito map to public to the public. They know where the mosquito density is high, where is low, and the government can conduct some control measure based on these outcomes.
Thank you. Last question. I see there are about 25 questions, but we cannot finish due to time limitation. The last question is about AMR. Could you let me see? Could you discuss the work that have been done in monitoring AMR through the One Health surveillance approach?
Yeah.
Yeah, the last question.
Yeah, for MLR, that's why we want to, in Shenzhen, the hospitals and the CDC and the animals are separated. That's why we want to develop this One Health AMR surveillance in the future. So that's our goal. Now it's very difficult because in Shenzhen there's no factory. Yeah, there's no wild room, wild animal. So sometimes because between the hospitals and the CDC, our goal is different. So that's maybe the next goals for the future. Thank you very much.
Thank you. Thank you for your questions. Thank you for your lecture and the answers.
Okay, thank you.
Due to time limitation, I cannot finish the reminding about 16 questions. Yes, still a lot of questions about this very interesting lecture. I think that you may have more communication and discussion with Professor Hu during a coffee break. Thank you.
Yes.
Thank you for your attendance.
Thank you very much.
Thank you, Professor Hu and Professor Zhang. May we now invite Professor Zhang to present a token of appreciation to our distinguished speaker, Professor Hu.
Thank you.
The souvenir represents of our gratitude for his enlightening speech. Let's take a photo. Thank you. Please be seated. We will now proceed to the second guest lecture on the topic, Public Health is on my plate, even when I am operating. May I now invite Dr. Ning Fan, founder of Health in Action, chairman of Forget Thee Not, and former president of MSF Hong Kong, and Dr. Nathan Tan, senior lecturer of SPH HKU, to share with us. Dr. Fan and Dr. Tan, please.
Thank you. Indeed, initially, thanks for Hong Kong U to invite me. But I think it's more like a sharing because I'm a rare animal in this room because I'm a surgeon. But why a surgeon is sitting here talking about public health, I think there is some transformation of my, I would not say my career because I'm still operating. Last week, I've operated on an elderly, more than 80 years old, is a liver cancer. But something struck me, I think more than 10 years ago, is I operated on a girl who suffered from gallstone, is as young as 16 years old. And I think something really is, in an aging society, maybe we focus about aging, but 16 years old is also aging. And if after operation, the girl continue to consume the fast food as a routine, because as she said, she have taken fried chicken every day, after school, every day. And remember, girls don't go alone. They go in a group. And that means a lot of girls is taking fried chicken after school. And what happened after 10 years, 20 years about those girls? I think the boys are not so happy because they are getting fat. But their heart vessel is damaging, is aging in a more rapid way. So I think job has not been done. So in the follow-up during my clinic, usually there will be a short lecture because we only have 3 minutes to see a patient. But for a surgeon, it's better because something has been done. So the 3 minutes lecture is about a lifestyle medicine. We try to prescribe the lifestyle to these girls or to anyone that I think there should be something more to be done. And so this starts slowly, and also with my experience with overseas, you can say, exposure to the MSF in the front line, to ICRC in the front line, that I start also to think that doctor is not alone. We work as a team. What I mean as a team in Hong Kong means the doctor make the order and you have a lot of people to follow your order. But indeed, it's not like that. We only part of the team. And a lot of public health specialists, a lot of nurse, pharmacists, dietitian, physiotherapists, social workers, or even is a public health workers. They are contributing to a person's health. And so slowly, I start my NGO, Health in Action. It's about health inequity, but we practice the health inequity. Forget Not is about end of life, and we practice how to put the advanced care plan into the routine of NGO, of elderly society, that the community can get the ownership. And Happy Aging Lab is about intergeneration housing. I'm only part of the team as a consultant because they also want to put public health in the intergeneration housing, especially after the COVID-19. So I try to help Nathan for the introduction because it may be a little bit slash, but I really think it's a work-life balance. Because I find it very relaxing for myself when I'm as a funeral director, as a life therapist, to help the people to overcome the grief. Because funeral is really very important. Of course, it's not the potayok. It's about celebration of life. Sorry, potayok. I don't know what is in English. Potayok. Anyone?
Literally translating, we're breaking
The traditional Chinese dancing in the funeral. Okay, I think the people will understand more.
Yeah. Those who know the Taoism culture would know. It's just one of the rituals being performed during a funeral procession. But just to, now if you know Fan, as long as I've known him, he's always off the script. So we have prepared something, but Fan is always very spontaneous. So, but it also demonstrates his mind. He's actually very brilliant. So I've known Fan more than 12 years already. The first time we met, it was in the board for the Doctors Without Borders. And that was the first time he called me into joining the governance so-called mechanism doing Doctors Without Borders. And ever since knowing Fan, you come to appreciate his humor, his humility, the way he thinks, and a lot of things. So just to share, I mean, you prepared certain slides just to help us understand your evolution, right? In terms of from a clinician and then humanitarian, and then you did all these places, and finally, as you mentioned, when you touched lastly on funeral director, maybe you can guide us through this map. What exactly you trying to tell us?
I think you just tell the people that doctors in Hong Kong indeed was everywhere around the world. Not because we immigrate out of Hong Kong, but we are really serving the world. Because there's really a lot of needs from the public health emergency. For example, recently Thailand, Myanmar, I know that Red Cross and MSF is calling doctor, nurse, and necessary engineer to help in our region. And I've been to Gaza, and I still think we need to really not to forget those people who are hidden, or indeed every day there is casualty and people who die. But I tell you that as a surgeon, what I mean is my happiness is not just operating. I still think about what I'm doing. Usually, you know, a surgeon is doing dirty job. We cut away those infected things, necrotic things. We cut away the cancer. But indeed, if you think about something really happy, indeed, what I'm most happy of the operation is indeed is doing something out of my field, is the cesarean section. Because we have to be trained to know how to do cesarean section in the field. And of course, the burr hole, the other things, the orthopedic. And I find it really nice because we bring life from operation. No other of course, you can say you treat the cancer, fine, you have done something. But this is one plus one. There are two lives, happy lives. So I find it really enjoying, and those are two babies who also have the name is Ning. Because in East Africa, their language have the pronunciation of Ning. Because the mother asked me what is my name. And I said, I'm Fan Ning. Good. I can use your Ning to put on the name of their son or girl. But after some time, I also have another feeling is, could they survive after leaving the hospital? Could they survive? Yeah.
But that's the challenge often for humanitarians, right? Very oftentimes you go into any emergency mission, you go in, you do your stuff, whatever, and then you leave, right? So you don't really know, as in compared to your routine clinician, as in a hospital, you follow your patient. After you do surgery, you see the recovery, and then see back probably in 6 weeks' time or 1 month's time. So you don't have that pleasure of following up in that sense, right? So how then do you kind of like dealing with this, manage to deal with it, say, all right, this is what I'm seeing, and then you have all this.
I think it's a career crisis. Really, because if you think, you have reflection, then you don't like to receive the appreciation letter from a patient. You don't want to see a patient. There should be no patient or less patient, especially not talking about in Africa or in Gaza. It's talking about in Hong Kong, a resourceful society. Why there are so many patients? Why the doctors, the nurse, or the allied health are working so hard, but still, patient coming in non-stop. And they deteriorate the health before they still can enjoy the quality of life. So this reflection, I think, when I go more and more to different places as a field worker, when I start to think about, I received a call from pediatric department of Hong Kong U about 7 years ago. It's about a baby girl, SMA type 1. The family members decided to bring the baby back to home because the baby girl have never enjoyed a home setting after giving birth.
So for those in the audience, so SMA type 1 means spinal muscular atrophy. So it's a neurodegenerative disease. So usually it presents at birth or within the first 6 months of life, where the baby will not be able to grow or develop normally. They will not be able to feed or even sit without support. So there's a lot of hypotonia and all this developmental delay to the point where they cannot even breathe because of the lack of the muscle power. So in this case, they would like to bring the baby back home.
Yeah, the baby already have a tracheostomy, have a gastrostomy for feeding, and the father, mother, and the family members all quit their job and learn how to take care of the baby. And after about 1 year, they decided to bring the baby back. And they also decided that the baby should die at home. And so they need support. Of course, there is a community team, but they still lack of a doctor who can go to the home to support it, I would say, or to make sure the dying at home is in a smooth process or a dignified process. And that's why I start to develop the dying at home service for my NGO. And interesting is the pediatricians already have assessed the baby, said she cannot pass her second birthday. But luckily, with the love of the family member, she passed her birthday. And this is the family photo on the day of birthday. Yeah.
I'm just curious, in sense of the palliative care that we have in Hong Kong here. So is there a particular gap where you think that I can actually do something more? That's why you started to have this NGO.
In a public health perspective, I think people who have been doing end of life in Hong Kong know that although it seems a lot of resources, there is a lot of research, but still talking about the palliative care. I would not say palliative care, but end of life support in the community is still lacking. For my NGO, they receive a lot of inquiry from the community, from the NGO, talking about their client, I would say client, or the community members is facing this, facing that, but they don't know how to get the support in the community. And the next follow-up, no matter the specialty is a surgical because of cancer, no matter it's a geriatric because of dementia, no matter it's orthopedic because still a lot of frail elderly, they will fall, but they also getting deteriorate in other system, and they are also need to have a very clear roadmap about what is my last journey or ongoing journey. And so this is a public health issue. In an aging society, we are not only talking about getting better, we are talking about how to have a better quality of life with support at home or in the elder homes in a smooth way. And this is public health issue because we will decrease them going back to hospital for unnecessary invasive investigation and intervention. Prescribing support and love at home is more important than calling 999 to go back to hospital. But we still lack of this mechanism. And I think I try to do the model is by supporting a regional group of NGO. Indeed, we can avoid this kind of the, you can say, unnecessary journey to hospital. I think times is, of course, is limited because of public health is a full scope. Maybe I can tell more is about, it's not an individual effort, but I try to do some modeling with the system. Maybe we can move further forward. Is first is this baby finally died at 2.5 years old, and they have a Buddhist ceremony at home, and then she leave the home with a death certificate, and then have the following process to be less regret for the family. And indeed, a lot of this kind of story was not alone. Later, a lot of nurse, allied health joined in the movement as a volunteer, and indeed, this is another really memorable ceremony. Is a retired nurse to help a nurse who died from breast cancer to lead their son and the husband to have a good memory of the nurse. They participate in the design, in how to reveal the life story of their mother. And we do live ceremony, what means a live party for a girl who is a terminal colorectal cancer in 30 years old, and resolve the family conflict. A lot of these things later have a chance that I can share with the medical student from the in their 5th year's curriculum. I lead them to see terminal patient, let them to know what in future as a doctor, no matter they will be a pediatrician, a surgeon, a physician, orthopedic, gynecologist. They know that they can do more for a dying patient by giving them the right message, the empathetic feeling, and guide them to have a better end-of-life journey.
So this one, sorry.
Yeah.
So this one's more on the...
Sorry, seems life cannot go back. Time cannot go back. Yeah, time can go back now.
So this is actually the advanced care planning, isn't it? That
Yes.
Curriculum for our medical students.
Yes.
It also involved the end-of-life communications,
Yes,
isn't it?
that's very important.
So, I mean, from those past few slides up to here, I think the part that you provide where, in terms of the public health, the formal authorities or those in the HA not able to provide is that support to the family and those caregivers within the community itself, really going out to the community to provide all this support, but also in terms of that communications, which I think is so important here. And we know everything in Hong Kong is time is money, right? And you need to be very efficient in things like that. So do you see, as in when you're trying to teach your medical students in terms of all this end-of-life communications, do you actually try to impress on them on the significance of these communications and then that supportive system, or do you find that they think it's something that it's actually our job as well?
I hope they will not follow my path. Is I only got this kind of the sense after I left medical school, because during my era there is no end-of-life training or even education. When the student approach the old gentleman, their routine is to ask history from the beginning. Although we brief them to start with caring message or even casual engagement, but as a routine, it's a reflex. Just a reflex. Is asking how are you? What is your symptom? What is your chief complaint? Yes, of course, they have chief complaint at that time. Usually it's pain, it's usually discomfort, or even I miss my family member. But we need this kind of the training for the students, so that for acute patient, for end-of-life patient, they have the kind of the already have I would say the sense that what should I do? What could I do? I would think what could I do is more important than what should I do. Sometimes just holding the patient or just caring for the patient or even look at the patient is better, because there is usually some joke many other colleagues is usually surgeon, when they know that this is a dying patient, they will not really engage the patient because they are too frightened. When they are holding the knife, they are brave, but when they see a patient dying, it seems that they don't know what to do, and they are quite afraid to approach the patient.
It's also that detachment, right?
Yes.
Being a clinician, we usually try to distance ourselves, do not get emotionally attached to our patients. So I think it's also that dilemma or conflict that we see.
Yeah, so I think Hong Kong today we don't have people from CU, HK, is it right? So I think Hong Kong U in this sense is the school. I mean the medical school is more advanced yes. Honestly, I also is an alumni of CUHK. Yeah.
Well, we are Hong Kong, Hi. Okay.
Time is running out, just like our life. Yeah. So just to let you know why KFC is so smart is yes, they know that the girls go in a group for the fried chicken. And we always talk about physical, but really this is very common phenomenon in a nursing restroom and also a doctor restroom.
I think even in our university campus, you can see the snack vendors and all this vending machine as well.
Yeah, that means the public health is difficult to practice.
And it's all about comfort food, right?
Comfort food.
You're also trying to give comfort to people, as in, all right, give you some chocolate, you can have that endorphin or whatever dopamine, right?
So going back, finally, is I really struck by this message. Luckily, Sir Michael Marmot, when he visited Hong Kong for the last 2 occasions, he came to our organization. We have some exchange about health equity issue in Hong Kong, and I really feel enlightened by what he's have been practicing. I hope I can do something more in Hong Kong. Yeah, and so for public health, there's too much things to be done, and my focus is about the working population, because I hope that when they retire, they are not forced to be retired because of the health. Is the first thing. The second is, if those people retire, they are being healthy or less disease, the general condition of our aging population will be better. So I think working population should be invest more. For example, their workplace, no matter it's about physical, social, mental, is quite important, because this is only the chance that we'll have a better elderly population. And I always say we are not alone, and medical professions should not be alone, because a lot of the policy that can make us to be better, have a better life, is from the other department. So a trans-sector collaboration and lobbying and also discussion is very important. Thanks to a lot of people here, including Professor Sophia Chen, Professor Yik-ying Yeoh has been giving me some learning guidance and also enlightenment that something could be done more. For example, through supporting St. James to run the DHC in some Shui Po, now we develop the CDCC. Through the community pharmacy development, now Jockey Cup can support the development of 18 districts to have the community pharmacy. And I've been involved in some of the works with other NGO that now we have the community living room. And I think to move forward is how to establish a healthy asset-based community that we can link up the people. For example, using the social prescription, the method, that to engage more people, to empower the different people that they can have a role or have the power to make Hong Kong people more healthy. Maybe I stop here, but something I really want some medical student here to know is don't talk these things to old lady, because everyone in Hong Kong from the kindergarten, we know about the harm of smoking. We know the harm of drinking. We know that we have to eat more vegetable. We know that we have to do more exercise. Just that, do we have the chance? Do we have the opportunity? For an old lady, maybe she lost all her teeth. She cannot look clearly. She only live on CSSA, the Social Security Scheme, and she cannot walk every day out of her home to the market to buy vegetable. And she has the osteoarthritis, that she cannot easily fry the vegetable. And we don't just want to eat very simple food that is prepared. Yeah. So I think I will stop here, and we can have time to have some exchange here.
Thank you, Dr. Fan and Dr. Tan, for your sharing. We will now proceed to the Q&A session. Audience can pose a question using the QR code. Please feel free to pose your questions, and Dr. Tan will moderate the session.
While we wait for a few more, let me see, after knowing you for 12 years, any more questions do I have for you? So in terms of, because you mentioned a few things. So one is on the asset-based community development. Another one's on social prescription, right? So these are all public health concepts as well. So just in case someone in the audience might not understand that, could you just elaborate a little bit about
Okay. I would think that usually we see even elderly just as a burden. But indeed, a lot of elderly, they can contribute back to the community. I think even for social prescription, seems that we prescribe something, no matter it's a social determinant of health factors, or we prescribe loneliness, the connection, that kind of the things. But if we always see the one we serve as a beneficiary, or have a sick role, maybe in a public health sense, then we cannot harvest the social capital that is so rich in Hong Kong. Everyone, after being supported or being enhanced, they can contribute back. And I think this kind of the sense may be the reason why, for example, we cannot usually find the man to come to the service is because of the identity issue. I really cannot contribute. I only need your help. A lot of loneliness people, are they really lonely, or because they are just disconnect, or we do not have the chance to let them to contribute their value. So I would think that even for the social prescription model, there is still something have to be combined with the asset-based community concept. Is we link them up, is to harvest their strength, but while at the same time we enhance them so that they can deliver their strength. And I see a lot of NGO in Hong Kong now want to involve in the social prescription, but they also still need quite a number of the public health support, for example, evaluation, how to monitor the effect, and this is something that there could be more to be done in the medical social collaboration.
Okay, we have 25 questions here. So please don't mind if I'm not able to really bring your question up. Do you encounter any difficulties while setting up your NGOs? This one's not just one, you had a few actually. So what were the challenges that you encountered when you were trying to set up an NGO in Hong Kong in particular? And based on, just building on that question, do you think nowadays, in the current social climate and or political climate, is it more difficult to actually set up an NGO in Hong Kong?
I think by not doing surgery is already a crisis. What I mean is, for me, it's very comfortable to go every day to hospital, to do the ward round, to do the endoscopy, to do the surgery. Once you want to step out of this zone to set up an NGO is already a crisis. So every day is a crisis management. How to keep the NGO to run. For example, Health in Action have 40 to to 45 staff, and we don't receive government subsidy. And for Forget-Me-Not, we have 15 staff. We also did not receive government subsidy. So the first thing is to make it sustainable and to use a business mindset to run the NGO. That means that we not doing service, we do sustainable impact model building. And then this is how we could get the people to buy in the concept. And the challenge is to get the funding, of course. But more than that is to think clearly about what is the root cause of the issue that I want to demonstrate. There is a solution. I think this is where the challenge is coming from. So a lot of discussion, meeting among the staff to get the staff to be engaged, because the staff have to buy in the value. And the things that they are doing is meaningful. I think this also involves the HR issue, that kind of the things, yeah. And also to manage my boss in the hospital.
All right, jumping next to the question, how do you think that medical and nursing training, or curriculum in particular, because you mentioned a lot of things about communication, empathy, and things like that. How do you think all this sort of training can be developed to strengthen, population medicine in the university? So, because one thing that we see is that as a clinician, you only treat, patient or individually, right? And in your case, or in, those of us who eventually ventured into public health, is because the more we see as a clinician, we feel we want to do more, right? So how can we, kind of like train this up instead of letting them, follow our path, after donkey years, then when they realize, oh no, that's more than this.
This is related to the first question, is about the challenge. It's a multidisciplinary team, must have conflict. And I would think that no matter it's a nursing school, it's a medical school, it's a physiologist, in their training, they should start from the first year to have more understanding about how to work as a transdisciplinary team. We work as a team. I learned it from the MSF field work, because in the morning it's the nurse who present the history and what she have done last night for the patient, and the physiotherapists, they spontaneously pick up the X-ray after the surgery and said that, okay, this one have the surgery on the knee. I will do this for this patient as a rehabilitation and aim to discharge the patient within 2 weeks. They don't need me to write an order. So that means that everyone was already well trained at school. Just that, do we have this kind of the working environment to let everyone can deliver their expertise?
This power imbalance.
Wow, power difference, okay. I would say this, if we believe health is a full potential of an individual, should we think that a healthy working environment is a full potential of each working discipline? If it's not a healthy working context, then how can we deliver health to individual? And in another words, is welcome people to send nurse, physiotherapist, social worker, or medical student. I will bring the medical student to the NGO to have a site visit to know how the people can work in a transdisciplinary way. And I hope more and more context is like this. Honestly, I don't think DSC is a transdisciplinary approach. We just change the leader from the doctor to the nurse. But things seems changing, but a truly transdisciplinary work should be the way for the future, because we have to leverage all the potential of the health, allied health, social worker, anyone in the society to maintain the people in an aging society to live healthily or less problematic in in the community.
I know time is up, but I've always, and I know a lot of want to know this one question. So based on your work, right, eventually, would you be a proponent for euthanasia in Hong Kong?
Point of turning. I really don't know, because in McKinsey, they have a saying that if 6% of people are willing to change, things will change. But I think in a professional field, for things to change, I think 6% is not enough, unless the 6% is from the leadership. But I still believe medical school, nursing school, physiotherapy school may be more easy, because we need the future generation to have a more open mind and more understanding about public health rather than just working silo. I think it's a very important way forward. And honestly, on another hand, I'm thinking the civil servant to understand more about public health is quite important, because finally, no matter what we do, we are aiming should be for a common outcome is a healthy city. And healthy city, all the things are related to different health, to different public policy, even down to elevation of poverty. Social inclusion are all in the healthy city. And so I see by no way our public policy leader do not understand public health. Or maybe they should have a mechanism that in order to promote to the head of the bureau, they should learn public health.
And they should come to our school.
Yes, yeah.
All right. So I just promoted our school, the public health program. Okay. Due to time constraints, and I apologize, we do have a lot of very good questions here. So apologize, I'm not able to do that. So can we all just appreciate Fan Ning's interview today? Thank you very much.
Thank you, Dr. Fan and Dr. Tan. Now may we invite Dr. Tan to present a token of appreciation to our distinguished speaker, Dr. Fan. This souvenir represents our gratitude for her enlightening speech. Let's take a photo. Thank you. Please be seated. It's now time for the intermission. Audience may take the opportunity to visit our poster session in the foyer. Please feel free to exchange ideas with our RPG student presenters. If you want to visit the washroom, those on the first floor are also available. Thank you, and see you at 11:25 a.m. We will now proceed to the roundtable discussion on the topic Research for Impact, Notes from the Field. May I now invite Professor Bashai to the stage to introduce our panelists today.
Well, just so revved up from seeing our posters and the enthusiasm of our scientists and researchers, our students and our guests from the Center for Health Protection. I want to go back. I wish we could spend more time looking at the posters. And in fact, I'm going to after this. This has been excellent. Well, let me move on to the next segment. This wrap-up session is really in keeping with the theme of the day in how do we translate science to better health. And our panelists are extremely well positioned to help us with this. Let me introduce them, starting with Professor Eng-kiong Yeoh. Professor Eng-kiong Yeoh has come to us from the Chinese University of Hong Kong, where he's the Professor of Public Health and the Director of the Center for Health Systems and Policy Research. He spans both academia and practice. He spent almost 2 decades working for the Hong Kong government, first as the head and the first chief executive of the Hospital Authority, where he really laid the groundwork for what is really an unparalleled public system of hospitals of excellence and quality. The people of Hong Kong rely on this system, and it is one of our jewels in Hong Kong quality of life. but then he also moved on to become the Secretary of Health and served there. So he gets us as public health. And then as a researcher, he knows what the evidence that we create in schools of public health, and he served as director of the Jockey Club School of Public Health and Primary Care. So he's well positioned to say, how do we translate the research that we do into public health? Our second guest today is Professor Y.Y. Teo, who is the Dean of the National University of Singapore, Swee Hock School of Public Health. And he also, because of the way Singapore runs its School of Public Health, he is in direct touch with the Singapore government health department, and also serves to help improve the quality of practice for the next generation, both in Singapore and in the region. The National University of Singapore, like excellent schools of public health everywhere, has an international focus and is working to train the next generation. Again, the concept of how do we use the science that we do in our laboratories and in our epidemiological surveillance systems, how do we make that practitionable? How do we translate it into the things that save lives? And we're so glad that he could come with us. His background is in statistics and economics and health systems policy. And our last guest is Dr. Rebecca Grais. And Rebecca has been to Hong Kong several times because she is the executive director of the Pasteur Network, and Hong Kong U is a node in the network of the Pasteur Network. She is also serving in policy in vaccines, working for the WHO as an advisor for the SAGE expert group. She has to focus on how the scientific community in the Pasteur Network can be of maximum value to governments everywhere. And so her perspective will help us understand that better. So I'm just so glad that we could do this, and I'm thrilled that they could come. And what we'll be doing is having our presentations here as a panel for 50 minutes, and then questions and answers at the last 10 minutes of the hour. So thank you for coming. I'm looking forward to this session. Could we invite our three guests up to the platform? So glad you could come. I'm going to start with Professor Eng-kiong Yeoh, and just let me work on your position as having been both in government and in research. Can you share examples where you saw research influence policy?
In fact, I was yeah, it's all right, yeah. In fact, I was quite struck by what Fan Ning was saying just now. We have got so many innovations in Hong Kong, so many really marvelous things, and yet the system doesn't seem to be working. Right? I think this is something which is phenomenal. It's not just Hong Kong. I think it's a global phenomenon, but in some places it's better than others. Because I think there are many issues that he raised, which he talked about, which is more in my context, even at that time as a policymaker. You're really trying to understand what can we do to improve things, improve health, right, using the research evidence. First, within government, you need to have that research, the policy capacity, right, to be able to do the policy analysis. Because if you don't know the problems, you can't find the right solution, right? So because many times, so when I teach policy, we talk about the garbage can models, where there are different policy problems which are framed very differently, and different solutions, right? And the solutions really were not intended for the policy, but we just put it there, right? Because it's just convenient. So one of the examples that we would have would be in terms of in Hong Kong, our elderly health voucher. We're spending more than $3 billion on health voucher, and it's doing nothing for the system. Because when I teach students, I say, what's the voucher there for? Hong Kong, we have this voucher that we give to everyone, so they just spend it for whatever they wish, right? But for public policy, for health systems, that's not what you intend to use that for. So the $3 billion is what we spend in totality for the whole of our primary care services, right? So when you do that, you're taking the solution to a problem which it cannot address, right? Because vouchers have been demonstrated in mainly for reproductive health, right? Because for things which are well defined, not underutilized, and then it must be very well designed. But our elderly health voucher is to let people to go for primary care, and it's not defined primary care from 14 different professions, right? So that is quite a big problem. So one of the issues is, of course, within government that needs to be that policy capacity, right, to really work with academia. So when you ask me about that, so the working with academia is so important. So during SARS, when I was secretary, I managed the SARS crisis. We had the Hong Kong University professors working, and then CU professors were not so involved at that time, but that's Professor Eng-kiong Yeoh, Malik, they were all working very closely with us because we really needed that knowledge, right? So that partnership is very important. And I think because also during that period, when we talk about the other issue in policy, is that the type of evidence you require for making policy decisions is not just from the biomedical field, right? It comes from social sciences, and many of that knowledge is not codified. So when I still remember the first time I talked to Eng-kiong Yeoh about when there was something that was happening in China, these respiratory illnesses, and there was also speculation what it was, and we didn't have any science then, right? So he from his experience, he was sharing with me what his thoughts were, right? Whether it was a new pathogen, or whether it was one of the pathogens that had changed its characteristics. So those were the type of things, because when you have an outbreak in the pandemic, you don't have that science, right? So where does the knowledge comes from? So the types of knowledge that are required comes from codified knowledge, which is the research knowledge that we have, but also what people call the non-codified or tacit and colloquial knowledge, the local contextual knowledge. But how do we capture that? How do we make sure that that is the best type of evidence that there is, because it resides in one person, right? And how reliable is that person? So it depends on whom you choose to listen to. So there are also methods in now that, because moving on to academia, which is quite interesting, because this is my fourth career, and I hope my last one in academia. So I'm interested in the policy sciences. In the policy sciences, one of the things that we're doing is we're looking at how to capture the texted knowledge residing in experts. And one of the methods that you do is through Delphis. Right? So Delphi techniques, there are different Delphi techniques, but one where you have a group Delphi. So if you had like 4 experts, you then get them together to discuss a problem, right? And then there you share, because people come from different fields, right? You can come from epidemiology, social sciences, and then they can challenge one another. You can debate the issues. So I think that method, to me, is one of the things that one can do. You have a more formal method that you ask people questions, right? And then how do you then derive the answers from the best possible knowledge that resides in individuals? And of course, that knowledge is not so-called the codified knowledge, but it's very, very important, right? It's very important because very often in the design of our public health systems, we don't have double-blind clinical trials. We don't have, so many of the things we do in public health, in health systems, you just have some references somewhere, but when you design the system, it's quite complex. And after that, the implementation is also another science, right? Because even with effectiveness, but when you translate it into real world, right? People's understanding is different. So there's so many barriers in public policy. One, of course, asking the right question. The second, getting the best expert advice you have. Third, designing it. And fourth, implementing it in the way that it should. I'll stop here.
Thank you so much. And this point about there being knowledge embedded in a person and getting people with that tacit knowledge is something that I think we'll be circling back to. Moving on to Professor Y.Y. Teo, part of what we brought up is this need to get policy implementers to take risks and change and not do the same old thing. What have you found might work with that capability to try out science-based policy innovations?
Thanks very much. Thanks very much, Professor Bishai. So I think the bit about getting policymakers to take risk, it must be linked to the way policymakers see what is on their local health agenda. Do they even know what's coming ahead? What are some of the health priorities? And this comes back to this health priority setting that governments, at least in my country, we go through to really understand what is coming ahead. So for example, if I use diabetes as an example of what Singapore has done, back in 2013 and 2014, it was the academia world that actually highlighted the burden, the disease burden of current and future diabetes to the Singapore government. And then we didn't just highlight it as a health burden, we also highlight it from an economic perspective. And economic, it's not just the direct medical cost, but also the social cost of diabetes, to really champion the idea that diabetes is a problem that cannot be ignored. And that raised an alarm to the Singapore government to say that diabetes is a future problem, that we must put in place the necessary investments in health, and not just in health, but in non-health sector as well, to really see what can we do to try and bend this curve. And this comes into this issue around governments now increasingly having this nationalistic plus short-term view towards their agenda, because politicians typically work on an electorate cycle that is either 4 or 5 years, and they may not necessarily be making the kind of decisions that is in the long-term benefit of a country. And this is where I see the science and the evidence coming in to help to set the agenda for the country, for the jurisdiction, to really highlight that in a world that we are living in right now, with ultra-processed food, with sedentary lifestyle, diabetes and other chronic conditions will cost more than pandemics. And right now, I think there is a lot of focus and spotlight shine on pandemics because the governments realize the economic impact. But many governments are not waking up to see the health emergency. We earlier on, Dr. Hu presented strategies around health emergencies. Diabetes and other chronic conditions are actually a slow-burning health emergency that the world isn't making the necessary policy decisions. And this is where I see the role that academia must come in to help to sound the alarm for some of this. And at the heart of it, back to your question around how do we convince governments to change direction or to take specific risk, it must come back to the ability to highlight to government what are some of the health priorities now and the future, and how do we prepare for those health priorities.
So thank you. It really also, you said putting a dollar value to show where the money is going to come and where those future financial burdens will be, and that will help with the prioritization process.
If I could just very quickly add on that, because that's precisely how we need schools of public health, academia, to now have a sense that, an understanding that policymakers throughout the different portfolios of the ministries are not necessarily compelled by health, but they will be compelled by arguments around the economy, around human capital. And the question is, how do we translate heat-related stress and injuries to a human capital, to a productivity perspective? How do we bring in the perspective of dengue to human capital and future economic perspective?
So I want to turn to Dr. Rebecca Grais with an international flavor of this. We today are benefiting from our guests in Shenzhen, our guests from Singapore. International learning helps with policy translation. So I want to ask Dr. Grais, what are the examples of that international learning on innovation and policy?
So I think I'll start with a couple things when we talk about policy. We've talked a lot about how it's important that policymakers understand science, policymakers understand evidence, but it's also important that scientists and clinicians understand policy. It's not just a one-way street. It's really important that communication and discussion is one which is essential to understand. And so I don't speak on behalf of a government, but on many, many governments and on an organization which doesn't represent one, but many different countries and institutions. And one of the things that's interesting in terms of moving forward is I was asked to take this position because it's a position of change. How do you bring innovation and centers of innovation and excellence, which are all around the world, how do you bring them to the attention of everyone? How do you scale that? How do you find success stories which occur all around the world and bring those to a much more global stage? And Dr. Bashai mentioned, and he's right, that we have one of the members of this network is based here. Pasteur HKU Research Poll, which we will then extend to be more incorporative of all of the entities of HKU in the future. But what is this thing? It's a translation of something old, which happened 200 years ago with Louis Pasteur. So when you drink pasteurized orange juice or you get a rabies vaccine, he had this idea 200 years ago that science could not contribute to society if it was constrained by borders. And if it was viewed as something national, we would never be able to advance as humans. And so due to history and the way the world works, these institutions were created all around the world, principally in former French colonies. But over time, lots of things happened. There was decolonization, there were shifts in the world, there are geopolitical shifts, and there was this big network, which really wasn't a network. It was just a whole bunch of things on paper that was there and hadn't really been used as the global good that it is. And by global good, I mean it's something which is not for profit and something which is aiming to contribute to the lives of individuals, no matter where they are in the world. And so part of my job is to create this mesh, is to create this infrastructure and this way of working which allows people all around the world to meet other people, to discuss what they're doing, to give their success stories, to talk about their failures, which is also something which is really important. Most of the time, lots of things fail, especially in science and even in medicine, and it's important to understand that, and to demystify and to help promote this idea that innovation and change can happen everywhere, and it's best done by people who are embedded in that community. It's not as well done when it's done in a centralized command and control manner. So to me, what's interesting in talking to all of you, many of you are students, which is in thinking about your future careers, there are many. And it doesn't necessarily mean that your career is based on where you publish or what you're doing. Contributing back and ensuring that what you're doing has a role for the society that you live in Hong Kong or elsewhere, is also the best way to move forward. It sounds harder, but it's something which is the most important if we're able to move forward and prevent, as YY mentioned, crisis, however that's viewed, whether that's a pandemic of a viral infection or whether that's chronic diseases and any other of the risks that we face. That all has to be done in a way that we ensure that everybody's voice is heard and that we value and look at what success means and achievement in a different way.
Thank you. I'm going to start throwing questions out to the entire panel, but reminding us about Louis Pasteur. I can just imagine Louis Pasteur going to his mentor back in the 1880s, says, you know, I got this call from the French wine growers and they're having a problem with spoiling wine. I think I'm going to go over to the vineyards and help out the French wine growers. The mentor would say, you're crazy. You'll never get a Lancet paper if you study wine in the hills of France. That's crazy. Go to the frontiers. Make path-breaking basic science. Louis Pasteur said, no, they're going to pay me, so I'm going to go and study this very applied problem in the wine growers. And that's the discovery of pasteurization and this empirical life-saving innovation. But mentors around the world are still saying what my fictitious mentor said. They're saying, applied work won't make you famous, go to the frontier. So now I'd like to ask our panel for our early career researchers, what's in it for an early career researcher to study an applied problem from a policymaker? Why wouldn't they want to do basic science and get 1,000 citations?
Right, maybe I could start from our perspective at the National University of Singapore. Currently, I have 2 offices that are based in Cambodia and in Laos. And in those 2 offices, we have full-time staff, academic staff, including PhD students that are working with the Ministries of Health in Cambodia and in Laos. We have similar arrangement without a physical office with Thailand, Philippines, Vietnam, and Brunei. So how do we actually convince our professors, not just the students, even the professors, that it is good for them to work with the Ministries of Health? And many of you who have had some experience working with the Ministries of Health, you would realize that at the very top of their agenda, it's never publications. And in fact, they may explicitly tell you, I can share the data with you, provided you don't publish it. But the insights that you get from your research is typically policy-directed research, typically evaluation of national programs, will be useful to help the governments, the province, change their policies or improve on their policies. So that type of research is important to conduct. But regrettably, most ministries of health or agencies of health may not have that spare capacity because they are often tasked to handle fire-burning stuff that they don't have the ability to look back and evaluate some of the things that they are currently doing. But that evaluation is extremely important. So we come in now to say that we will help you look at evaluating some of this policy, look at advocating some of your new health priorities for you. But in order to do that, I must have a team of workers. And these workers will be professors, will be junior researchers who are going to build their own career in academia, in research, as well as PhD students who want to publish. And we need to assure them that by doing this, it is not jeopardizing their academic career. In the university that I'm in, we have been very fortunate that whether it is tenured professors or professors on the tenure track or practice professors, there is this explicit recognition of policy impact of practice-related work as long as it contributes to a health agenda. And this recognition officially needs to be provided by the policymakers. So if I'm working with Cambodia government, actually some of the senior director generals of health will be the one writing a letter to say, how has this professor contributed to some of the work that we have done? Those our university recognize those. And I think this is an important step that universities need to change and need to adapt to. Right now, regrettably, there are many universities, like what David, you have mentioned, they recognize publications because of international rankings. But if we look at what's happening in the world right now, at this precise moment, with US imploding on its own, This whole point of university rankings, in my opinion, those of you who work in global health, you would have heard this phrase, decolonizing global health. It is trying to shift the attention towards much more equitable approaches to recognize, to award, and to execute global health activities. In my opinion, university rankings need to be decolonized as well, because there is a huge preference on English-speaking academic journals. It is just an engine that is just churning itself to produce more academic papers. Now, if you think about the world that we live in right now, you would realize that the world is actually shifting towards more impact, towards more social impact types of research. And that's where I see that in the next 10, 20 years, universities will be forced to change towards recognizing more real-world impact rather than just theoretical academic impact. If you look at universities 100, 200 years ago, they were all about social impact. They were all about solving real-world problems. It's only recently, in the past 20, 30 years, that the world has caught onto this university rankings and each trying to outbid each other on what? On academic publications that may not translate to real-world impact. On grant funding, again, it is a superficial cycle. So I actually see that there will be a change coming in the university world. And from my perspective, I would hope that universities start to adopt a very clear lens on recognizing real-world impact. But at the same time, when we say recognizing real-world impact, it is also about incentivizing your own professors, your own students to do real-world impact work.
Yeah, I was thinking about, because I teach year 5 medical students, a session on health systems and policy. And of course, the students are not really interested, and they're just interested in clinical medicine. So it's a challenge, and I take, because I was in CU, we split our students in year 5 to 4 groups. So I take four times a year, and every time I think about how am I going to get them to at least appreciate it, right? And so sometimes I ask our faculty, why am I teaching it, right? But of course, it's important. It's important. So what I try to do is I relate it in terms of what it means for clinical practice, right? So obviously things about the terms of health, right? So you're seeing patients, so like Fan Ning was saying, the patients come to you, but you send them back, and they get the same problem, like Sir Michael Marmot said, right? And then when you look in terms of the systems, that your policies right now, government is trying to increase the user charges. Patients don't come. You have beautiful we have beautiful hospitals, excellent equipment, excellent doctors and nurses, but access is a problem. Why is it a problem? So I tell the students, when you go and see your patients, right? It doesn't matter how good you are, because the patients are the key people that contribute to health. You need to understand, right, health behaviors, right? You need to understand beyond the clinical medicine. So to put it in the context of why they need to at least understand that and appreciate it. So I'm not asking them to be behavioral scientists, etc. So that's what I try to do to them. And of course, the whole field of public health is so wide. And for students here, some of you may not be ready to go into it. Some of you may, because depending on your own perspectives. So I'm sure David will give them some perspectives of the career in public health. If you go in, how do you start? Because there are many opportunities. But some of you may only go in later on, right? You may go in after you've done your specialty. I came in quite late. I was a gastroenterologist. I was internist. I managed a very acute hospital. I became also the executive. And then I realized the importance of looking at some of these things beyond just, because I loved clinical medicine. But I saw that you need to do more than that, right? So that it could also be part of your career as you move on. So your opportunities are there all the time. You can move into public health anytime. And then the whole field of public health is so rich. There's so many opportunities. When you go into clinical medicine, it's very, very narrow field. But public health is so broad, so rich, and so rewarding, right? so rewarding in terms of the impact that you can make. And basically on the academia part, in Hong Kong, fortunately, we are now moving towards doing our research assessment exercise, look at impact. And then we also look in terms, we just don't look at the factors, but also the journal's publication in sort of ranking within that specialty. But I think the impact assessment is now a quite important part of the research assessment exercise. And people realize then you need to go beyond that. And it's important also for yourselves, like what we're saying, you just don't want to be part of that machinery. So I see a lot of papers, you have a lot of publications, but they're meaningless. There's no research question. It doesn't contribute to any knowledge. It confuses the literature, right? So what we're seeing now is people, the mad rush in terms of going 1,000, 2,000 papers, but when you see it's a replication, right, of many things, no contribution to knowledge. But I think universities are increasingly recognize that that's going to be important. So certainly in our university, we now start to look at some of the types of work that are being done, the research questions, and the research assessment exercise does that. So I think we have very good, because I've been involved in some of those, the external people really are very good. They really don't look at the impact factor of your papers. They look at your research questions and whether you're actually contributing knowledge. So that's quite important in terms of for junior people, not just to generate numbers.
Yeah, I was just going to add two things. I think one, which is very simple, which is it's very easy for people that have published a lot to talk about how it's not that important. So that's always the case. That's the case for myself. That's the case for all of us on this panel, I'm sure. But I can tell you that at the end of your life, or when you think about it, pretty much nobody says, gosh, I wish I would have published another paper. When you think about yourself as a contribution, as a person, as a friend, as a mother, as a daughter, as a sister, it's really not something, and it's not the best way to view your contribution. The second part, which is more structural, which I just wanted to talk about as an example, and why I mentioned this, is within the network, which is 33 institutions all around the world, of which 70% are located in the Global South, we have a new program. And this new program, which is funded by the Rockefeller Foundation and also the Institute of Philanthropy, aims to help train and address career pathways for scientists and public health professionals towards policy, and in specifically around the impacts of climate change. And so these are 17 young people, many of whom are probably your age. They're young researchers. And the way that they're evaluated is not by their number of publications or the number of research grants raised, but by their connections with others around the world, with their ability and their interaction with either local policymakers, so your doctor in the health clinic, all the way up to a minister of health, and also, of course, a minister of finance. And then in addition to that, their ability to communicate science, to communicate their research, and to come up with ways to explain what they're doing to people who are non-scientists or non-clinicians. And that's how we look at them. Doesn't really matter how many papers or if they publish papers or not. It matters what they're able to contribute back. And that this is a small program, but one which could be something that could take off in the future. The last thing I'll say, which I mentioned, which is the decolonization of global health. Global health is a complicated concept because anytime you bring up the word global health, it has power inequities built into the concept. Most of the time when people say global health, what they really mean is people with money funding people that don't have money to work on a subject of interest to them. And so one of the things that we're working on within the network is ensuring that those power imbalances are ones which we can address. ones where it's not something which is focused on a high-income country. It's not centralized, where the value and the understanding of innovation and success is one that transforms. And I do think that HKU plays a very important role in all of this, not only in the ecosystem here, in the government of Hong Kong, in the city of Hong Kong, but also globally. And so I very much look forward to all of you, all of the students here becoming international professionals. One last thing before I stop. The more languages you can speak, the better. So I greatly encourage you to do that.
Thank you. Let me move to something that Dr. Ning Fan brought up, which is an approach based on looking at the strengths of the community, asset-based approaches, which are, again, very useful in the work of translating science to policy. So could I ask you to think about the assets that help with policy translation? What would you put on the top of the list of assets that organizations, laws, regulations, people, what is it that will help us move forward?
So there's many ways you can answer that question, but I'll start with one which is very easy. I think one of the biggest assets is people who do not take themselves so seriously. Why I brought this up, in policy land, health is not really always at the top of the list. It's much more likely that policy professionals and people you're interacting with care a lot more about superconductors, chips, their own personal legacy, the geopolitics of everything that's going on. So understanding where you, as an individual, wherever you are in your life and in your career, fit into this larger picture helps a lot. And recognizing that not everybody understands what a full professor is, an associate professor is, an assistant professor is. That's not necessarily something that people who are in politics or policy understand or even care about. And so on an individual level, it's being able to be humble and being able to communicate your knowledge in a way that a 12-year-old understands, that an 80-year-old understands, and that is something that you can clearly translate into a benefit for others. On an institutional level, translating into policy, it's much more what I was just trying to explain is valuing and explicitly ensuring that scientists and public health professionals have a pathway towards a career which is not just based on what they produce in terms of publications or grants. It's based on what they contribute back to the community, how they contribute to global goods, and how they interact with others in this larger ecosystem.
Yeah, I think really a lot of things that Fan Ning said were things that have always been on my mind, because having worked in government, because I was Secretary for Health, not just health, social welfare and food, right? So I had both social welfare. In fact, I had the biggest government portfolio. So I had social services, I had social security, I had food and environmental hygiene. I had a big portfolio. But it was quite interesting because in that, when you see the way that our NGOs work, Fan Ning is quite unusual in his approach. We treat people as if they need care, whereas they contribute to the care process. So to me, the assets, it's in two things. One is the mindset in terms of, and the second is how we define assets. Right? How do you define assets? The mindset is that we do not think as people as assets. We are every country looks at the economic growth, technology, and then what about all the other people that are left out? We're now going to look into AI, technology. Everyone's got bandwagon on AI, but how many people will be involved in AI? Right? How many people will be involved in the industry? What does it mean? I mean, what is AI there for? So it's really the assets are the individuals, the people in the community, and we do not use those resources. So many people who are disabled are assets, right? They can do many things, right? It's a question of enabling, putting an environment. I have a relative that's lost her sight 50 years ago, has peripheral neuropathy, no feelings, immigrated to Australia, brought up two girls with a husband, no help, right, in New Zealand, right? And she's still, without her sight and without feelings, she does many things herself. She even goes to the gym 5 days a week and does rowing. So that the assets are there. That's in the individual. So we need to value those assets and people's capability and capacity. And there's so many resources in the community. Like Fan Ning was saying, how do you actually enable that? The environment that permits it, right? And when you top down, we just look at just a peripheral part of the assets that we have. So we don't look at all the assets we have, the people that we have, their contributions to life. I mean, what's all the economy there for? It's really for the people there, right? The value that we put on individuals. So I think that's something that we need to really keep emphasizing, because public health is about people, is about humanity, right? So it's about equity, social justice. Why? Because everyone there should be valued as much as another person, right? And really, that's what society should be about, and should really be valuing all the assets that we have, and the ability to contribute to the greater good of society are the assets. And greater good of society is not just economically, it's socially, morally, right? So those are elements of those assets that we have that we not define, right? So the moral assets, the cultural assets, those are assets to the community. The well-being of the community depends on those.
What Professor Yik-ying Yeoh was just bringing up was a different form of prioritizing. We talked about prioritizing problems by the burden of diabetes, the burden of perhaps an infectious disease threat. But we can prioritize by the strength of our assets, and if we've got some strong assets, they would direct how we prioritize. Let me bring up a very current event, which is diplomacy, and how we have just this week entered a global trade war. And we've also seen the instigator of the trade war take a war on global health and do whatever it can to get in the way of the field of global health, get in the way of health as a way to create diplomacy. What can we do at this particular moment as a community of public health to point out what we can contribute to solving a problem of mistrust and trade wars? What does our profession offer for health and diplomacy?
I'm going to try and start. So Rebecca would know that some of us are part of this global commission looking at the global threats to health for the next 75 years for the world. And we have been mapping out what is likely to threaten the health of populations worldwide. And this breakdown in global governance structure is indeed a highly threatening one. But at the same time, I think many of you would have heard narratives that it is actually not necessarily just a crisis, but how do you view it from the perspective of an opportunity? And this is where I will be much more operational rather than strategic. If we start to see that the current global version or global consensus version that we have been relying for the past 50 years, past 70 years, ever since the end of the Second World War, where we established the Bretton Woods institutions like the International Monetary Fund, like the UN, United Nations. This is gradually, increasingly becoming less relevant in the current world that we live in. The question is then, there is going to be a gap in the way the world thinks about big problems. And big problems include climate. It includes the role of malicious artificial intelligence. Big problems also include our inability to find good solutions to pandemics because of this divide between global north and global south. And also potentially, we haven't heard about antimicrobial resistance today, but I will just include, because those are, in my opinion, some of the biggest threats to the health of worldwide populations. Whether you are in a global north country or you're in the global south countries, all the 4 things that I've mentioned will affect everyone. But if you now look at it from the perspective that the United Nations approach, that we are able to come together to recognize the problem, to put financing and resourcing includes human capital, human resources on the table to tackle the problem and to find solutions jointly, that model is no longer available to us. The question then is, what is next? And I think there are very encouraging signs to see what the African Union has done during the COVID-19 crisis, to see what the European Union actually did, that they were able to come together as a bloc to buy vaccines, to negotiate vaccines as a bloc to subsequently distribute to its members. I come from a country in Southeast Asia. We have ASEAN. The question that we have been discussing recently in the past few months, ever since the breakdown of USAID, is what is the role that ASEAN is now able to step up to tackle issues around the departure of technical assistance that used to be funded by USAID? What are the problems in ASEAN that is ours, that we own? For example, dengue. Dengue is a big problem in my part of the world. But how do we find solutions to that? Regional diplomacy may now seem to be an increasingly important approach. And actually, because when you work amongst your country neighbors, you are much more likely to be invested because, and that is helping us to address some of the solutions that are much more immediate in terms of vaccine shortfalls, in terms of stepping up technical assistance for maternal child health. And the question is, while we are able to plug some of these gaps from an emergency fund approach, in the long term, you would start to see that some of these alliances will only solidify and you build greater trust that a regional model is now going to be much more functional than always aspiring towards this global consensus model that is increasingly difficult. Because once the US is not part of the WHO, to what extent does a pandemic agreement now has any real-world impact? And countries around are going to say that US is not going to sign up to the pandemic treaty. Why should China, why should Indonesia, the other countries be kept to a rule that may disadvantage themselves nationally when a pandemic crisis arises? And I think this is exactly what I meant earlier on, when we have to understand that the new world now that we are in is that countries are increasingly going to make decisions for themselves because the politicians are making decisions that are short-term in nature. And the question is, I pose this back to many of us here because we are in academia. To what extent do you see your own role to help identify what are the priorities in your region and then to sound that out to the government, as well as develop some of the platforms such that you can also learn what are the pain points, what are some of the health priorities that the government is facing, and how we as academia will be able to help them solve some of these real-world problems.
Can we show the QR code for the staff? We're going to turn over to Q&A, and so when you see the QR code, you can start sending your questions. Thank you. And while we're waiting for questions to appear on my iPad, I wanted to go back to what we started with an hour ago about governments that get stuck in a rut. EK was talking about the co-care vouchers, which was a policy that needed to be watched and reformed, and the government's not as rapid as we'd like it to be at learning how to adapt. What can we do as researchers to create more rapid cycles of adaptation, to be watching a policy, checking it, and going through the evaluation cycle faster?
I think that there are several ways you can do it. One, obviously, in Singapore, with a very close relationship with government. So governments will engage with academia right at the upfront. So we did this once for the district health system. So but they sent up invitations to academic institutions to evaluate the district health system, but it was a formative evaluation, right? So that was quite good. So you evaluate as the model develops. So you don't do it 4 years later when there's a disaster. So that's one way to do it. The second way is, of course, now, currently, the government is doing this review of fees and charges. And I think many of us are quite concerned in terms of what impact it will have. Right? Although it's not, in terms of the cost recovery, it's not substantial compared to other countries, but the difference is quite substantial for the people that are going to be involved. So there, academia could start doing some of the studies, right? Because the policy is supposed to be implemented, or even if it's implemented, we could do some of these studies very quickly, right? And just to look at the impact, so it can affect how policy can be adjusted. So those are things that you can do. Of course, you could engage with policymakers. But very often, when you do a policy, government wants you to do the groundwork, to do the design. They're fine, but of course, very often they don't. Right? So the design of policies is also quite problematic from my experience, because it's not based on any evidence, any science, right? It's based on the policymaker's previous decision, or someone just said that the influence in terms of who said this, you should be doing this as a design. Because there's so many solutions. Like currently with this policy on increasing user charges, we already have a lot of people giving different advices in terms of what should be done. So in academia, for us, if we think we know how to inform policy, we should be starting some studies ourselves, right? And we don't need to wait for to come to us. Right?
I'm getting lots of questions here, and I'm not going to be able to have time for all of them. One of the questions is about our region. With the U.S. withdrawal from global health, can our region take on leadership? Can China, can Hong Kong, Singapore? What will our region be called to do in global health?
I think every region is going to be called to step up. Just to follow up on what Weiwei was discussing. So there are always advantages and disadvantages to centralized global systems. But one of the biggest advantages, which Weiwei was mentioning, was you often care more about your neighbors than you do about people that are far away. So regionalization and the importance of that in the coming years, I think, is extremely critical. In terms of Asia, you have to. I wouldn't even say that this is a choice. This is a necessity, and it should have been there even more so before. And one of the ways to do that is by sharing lessons. Even, for example, this morning, the discussion about the system in Shenzhen, that's fantastic. That's something which could serve as a model and a discussion that could be used for many other countries in the world. The second is by engaging, I think, in other regions as well, not just focusing on a local approach and a regional one, but also having lessons from that regional setup and the way that it's done to other regions in the world.
Also, going back of what David was saying about the current crisis, I think systems are organic things. They're complex systems. We cannot control them. All right. So, like why I was saying that there are opportunities, and of course, I think for us in academia, I mean, to me, we should be doing whatever we have been doing, and looking in terms of opportunities, right, to build those networks, because there's not going to be suddenly a new alternative emerging, and nobody's going to be able to do that. There's no leadership for that. And even then, it may not work, because many of these things are in complex theories about emergent systems, right? So it's really by nature, when you're forced to work together, when you don't have the global order, right? Then these networks like yours work, because that's where like you say, in Pasteur's vision, science is global, right? Truly global, and then our networks, academia, is also global. I mean, the affiliations that we build, they're global. It doesn't matter which country you come from. I mean, you share a common value. And then those things will evolve, right? And that's going to be very good because you don't have that so-called world order that's being determined artificially. Then there are no, in fact, it's quite good. There are no rules of the game. We have a lot of rules of the game, and that's why America is so keen to keep that world order, because they have dictated the rules of the game, and they want to continue to dictate the rules of the game. And the presidency said, no way. So there's a flux, right? It's uncertainty. So that's a good thing, right? So we just need to see what the new world order, what emerges, and we just have to go through that.
Thank you. Do you want to respond? No. Okay. Last question before we close is a question really targeted at EK, but I think a lot of us want to answer. You brought up the Delphi model for policy research. Is there an alternative, like deliberative polling, where the opinions come from the community? Could you say more about that?
Well, yes, I think there are many different methods. I mean, depending on what the question, right, that you have, and the complexity of it, and then who you want to involve. So I think there are very different methods, but the important thing is how do they generate that best knowledge from the non-codified way. So there are different mechanisms that we can do in terms of these, as you said, the polling, even the Delphi methods. There are very different types of methods that you can do for different purposes. Right?
Okay, so we have 3 minutes. I'm going to give the microphone to each of you for a last roundup. We'll start with you, YY.
Right. So thanks very much, David, for invitation and also for the opportunity to think about some of these issues. I will just round up by using your second last question around what is the role that Asia can play in the world that we are facing these days. My honest opinion is that jurisdictions like Hong Kong, countries like China, Singapore, and Thailand actually have a very big role to step into. Because if I use just Hong Kong as an example, Hong Kong Jockey Club, it's now led by Professor Gabriel Leong, and he and his team have been going around the world trying to identify what are some of the gaps and how Hong Kong Jockey Club can actually step in to help co-create. The key word here is exactly around this decolonization of global health. It's not a funder coming in to say, I'm going to give you money to tackle HIV/AIDS, but around what are your problems and what are your needs, and to identify. At the same time, when we think about assistance, there are two types of three types. One is financing, I talk about it. The other two types, it will be human resource as well as access to technology. And if we look at Asia actually, it's coming up with a lot of new technologies, whether it is in health or in non-health sector, particularly in China. And if we see the ability that Asia is able to now contribute to the world stage, to Africa, to Latin America, even to Europe, to North America, new technologies to address some of the issues around development. I will use the word development because it is then not constrained to health. Then you realize that actually Asia does have quite a big role. The last resource is human technical expertise. We have a lot of people in our countries and jurisdiction. We also have very top-notch universities and education institutions that is able to generate the necessary human capital. As someone who's from Asia, I'm actually thinking that the next 30, 50 years, we have these free resources that we can offer to the world. And I like to think that we are a lot more humble in the way that we approach trying to solve problems. We don't go and say, I have the solution, you listen to me. But typically, we will look at, in your context, what are some of the issues towards climate? How do we try and identify solutions that way? And I think that approach actually will help us advance towards a better world, if we put it in a cliche manner. Thank you.
Last comments? Rebecca, last closing?
Yeah, I think just to close, so first of all, I would love to take all of you students with me around the world because I think that that's Something else which is extremely powerful is the ability to speak with other people, and by speaking to other people, you can understand how to do and communicate policy and science better. And just to tail on to the discussion about where do you get this non-codified information, well, you get it from yourselves, and you get it from the people you know and where you work. I worked for a very long time in the Sahel, and I worked in a country called Niger, which many people said to me, "Don't you mean Nigeria?" And I had to explain to them that no, this is actually another country. And one of the things there, which actually did translate into policy, was being more flexible with childhood vaccination. So when you talk to moms, or you talk to somebody like me, I have children, this is my field, I'm probably in the top 1% of humans in the world in terms of my education and background, and I could not successfully vaccinate my children on time. I was unable to do that. I was not organized enough, I couldn't do it. So if you're a mom who's living in a place where you have to walk 5 kilometers or 10 kilometers each time to bring your kid to the health clinic to vaccinate them, one of the big policy changes was just putting a group of mothers together to speak with the Ministry of Health about making vaccination schedules a little more flexible. And so what I mean by that is you have the answers. What you need to focus on is also how to communicate them. What your problems are often what other people's problems are. And by participating in this system and being active and not viewing science as an ultimatum to publish, but as one where you want to improve people's lives, you can make a difference for yourself, for your children, and for everybody else.
Just for the researchers and the students, I think I just want to say that what struck me is saying that knowledge is always tentative, right? So when you read a lot of the evidence and you're very strong about it, there's some basis for it. There's some assumptions. So knowledge is based on some assumptions. And of course, the biggest truth is when those assumptions are being questioned, right? So that's the biggest impact when you review the basis of that knowledge. So that's going to be very important in terms of if you want to have impact if eventually you maybe become very renowned. But this important thing, the other thing which we ask questions which are important, right? Important in the context of people about the things, and not just about number of publications. And also when you look at your methods. I think the co-creation is so important, and understanding, working with people, right? When you design studies, design it with the people, with people around you, with the patients, with the ones that you do. That is quite important, really, to get the input, right? Then it becomes meaningful, the impact. So impact is important for the people that are being involved in that research, and the people that will benefit from that research.
Great. Thank you for this session. I think we're going to be wrapping up.
Thank you, Professor Yeoh, Professor Teo, Dr. Grais, and Dr. Bashai. Now may we invite Professor Bashai to present a token of appreciation to our distinguished speakers, Professor Yeoh, Professor Teo, and Dr. Grais. This souvenir represents of our gratitude for your enlightening sharing. Let's take a photo. Thank you. Please be seated. We will now present the Best Poster Award. May we invite Professor Maria Zhu and Professor Bashai to the stage for the award presentation. Professor Zhu and Professor Bashai, please.
Okay, so ladies and gentlemen, we've now arrived at one of the most anticipated moments of today's forum, the award presentation. So I can feel the excitement in this room, and it's truly an honor to represent our panel member to announce the Best Poster Award of this forum. So it is the most exciting moment now. This year, our second runner-up goes to Scarlett Law Hei Tun. So, please. Yes. Okay, and our first runner-up is Whitney O Wing Ying. Okay. Congratulations. And now, the moment we've all been waiting for, the grand prize. And the winner is Tiffany Ma Ziwai. Okay. So let's give them a huge round of applause for their remarkable achievements. And thank you all for sharing this celebrate moment and making this forum a success. And please return to your seats and let's enjoy the rest of our day and keep the conversations going. Yeah.
Yeah, I did want to thank the poster committee. Thanks to Maria and Youngwon Kim, who couldn't be with us this morning. And there were judges too, and I want to thank the judges. It was really hard for the judges, I know, because the posters were all so good. Professor Peng Wu, Huiling Yan, Ri Hong Chung, Jessica Wong, Parko Shu, and Annabelle He. Thank you so much for serving as our judges. I think I'm going to go on to closing remarks now, and let me start to close our day together. I'm just so filled with both pride and optimism. It's hard to be optimistic, but I think we can be. Look at what we're able to come together to do. I think what has held our progress together is in what we do in a university and in a school of public health, and the posters are witness to that brilliance. And the remarks from our guests, starting from our Professor Hu and Ning Fan and our panelists, show how science is helping create better lives every day. We've had great discussions. All of you have made networks. You've shared your QR codes of your WhatsApps, shared business cards. So that network will also carry us forward in our mission. I want to express gratitude and gratefulness. Events like this really take a lot of work. I want to be thankful to our organizing committee. Several of our faculty worked to think through what to do today. Professor Ben Cowling, Professor Dennis Ip, Wendy Lam, Professor Tommy Lam, Karen Greppin, Joni Zhang, and our students. We had students from both the undergrad, MPH, and PhDs, Adriana, Joanna, and Siu. Thank you for your service. And then it was a lot of work. I think Vincent, there's Vincent. Really need to give him a round of applause. Thank you, Vincent, for bringing this all together. And Crystal, your team, Crystal Lau is our communication manager. Thank you to Crystal. Please give her a round of applause. Her team has worked tirelessly to put this together. So as we move beyond Public Health Week, this week comes just for 1 week, but it really should be Public Health Year, Public Health Decade, Public Health Century. Our work never stops. We have momentum today. So let us continue to advocate for evidence-based policies. And let's do the type of work that puts us in touch with the assets in our communities, the sort of scientists that are attuned to what is strong in our populations and how we can contribute what we offer. So in closing, I encourage each of you to reflect on the insights you've gained today and the networks that you've grown today by meeting others, and reflect on how you can incorporate this in your future work. remember that public health is not just the responsibility of a few elite people. It's really the work of a large group of our communities. It's a collective effort. So again, thank you all for your participation and coming today. Thank you for your commitment to advancing public health. And together, we can make a difference.
Thank you, Professor Bashai. Please be seated. This is the end of today's program. On behalf of the school, I would like to express our appreciation for joining us today. We hope you have taken home inspirations. If you would like to take the shuttle bus to Kennedy Town MTR station, please make your way to the main entrance of 5 Sassoon Road, the Jockey Club building for interdisciplinary research before 12:55 to catch the ride. Our staff will show you the way. Thank you once again for participating in our forum. Have a pleasant day. Goodbye.